Think about the last time you mentioned something to your doctor that felt vague and hard to explain. Not a sharp pain or a dramatic symptom, something subtler. A tiredness that coffee does not touch. An itch on your arms and back that appears at night without any rash to explain it. A heaviness in your upper right abdomen that comes and goes. A sense that your thinking is slower than it used to be, that words take a fraction longer to arrive, that you feel foggy in a way that does not lift the way ordinary tiredness does. Your doctor listened, ordered some tests, and came back with an explanation that had nothing to do with your liver. Stress, aging, anxiety, dry skin, irritable bowel, a vitamin deficiency, something that explained one symptom without ever connecting it to the others, and you left with a prescription or a recommendation that addressed the surface while whatever was producing the symptoms kept doing what it was doing. This is not a failure of medical care in the dramatic sense. It is a structural problem in how liver disease presents and how it is evaluated. The liver is the only organ in the body with enough functional reserve to lose more than half its capacity without producing a single abnormal result on the blood tests used to screen for it. Liver enzymes, the markers that appear on standard panels, measure liver cell damage. They do not measure liver function. A liver that has lost significant function without active cell death produces normal enzymes while delivering abnormal performance to the 1,200 processes it is responsible for every single day. The result is a gap between what the liver is doing and what the testing is catching, and that gap is filled by symptoms. Symptoms that appear months or years before any laboratory value crosses a diagnostic threshold. Symptoms that get explained away by other causes because nobody is looking at the liver yet, and symptoms that, taken together as a pattern rather than individually as isolated complaints, tell a story that any clinician trained to recognize it would immediately connect to the organ producing them. A 2021 review published in the Journal of Hepatology analyzed the clinical records of adults diagnosed with chronic liver disease and traced the timeline of symptom onset relative to diagnosis. In 74% of cases, at least 3 of the symptoms covered in this video had been documented in the patient's medical record, attributed to other causes for an average of 3 years before the liver diagnosis was made. 3 years of signals, multiple clinical encounters, no connection made until the disease had progressed far enough that standard testing finally caught up. The 7 signs covered today are the ones that appear earliest, the ones most frequently misattributed, and the ones that together form the pattern the liver uses to communicate what no blood test is yet measuring. The 7th is the most commonly dismissed. The first is the one that, when present alongside any 2 others on this list, nephrologists and hepatologists describe as grounds for immediate liver evaluation, regardless of what enzyme levels show. Before we begin, tell us in the comments right now. How old are you, and where are you watching from? And have you experienced any of these symptoms without ever having your liver specifically evaluated? Drop it below. We read and respond to every single comment. Number 7, persistent fatigue and brain fog that sleep does not resolve. This is the symptom that brings more people to their doctor than any other on this list, and it is the one most consistently explained away before the liver is ever considered. Fatigue is attributed to everything: poor sleep, stress, depression, thyroid problems, anemia. It appears on the differential diagnosis for dozens of conditions, which means that in practice, it often ends up attributed to whichever explanation is easiest to reach rather than whichever one is actually responsible. The liver-specific fatigue mechanism is distinct enough from other causes that understanding it changes how you evaluate your own experience of it. The liver is responsible for clearing ammonia from the bloodstream. Ammonia is a byproduct of protein metabolism, produced continuously by the gut bacteria and absorbed into the portal circulation before reaching the liver. A healthy liver converts this ammonia into urea efficiently and continuously, keeping blood ammonia levels within a range that the brain can tolerate without functional disruption. When liver function declines, ammonia clearance becomes less efficient, not necessarily to the levels that produce the overt confusion of clinical hepatic encephalopathy, but to subclinical levels that affect neurotransmitter balance and brain cell function in ways that produce cognitive slowing, difficulty concentrating, word-finding problems, and a pervasive mental heaviness that the person experiencing it often describes as feeling like thinking through fog. The fatigue component operates through a related but distinct mechanism. The liver produces albumin, the primary protein in the blood that maintains oncotic pressure and transports hormones, medications, and nutrients throughout the body. It produces the clotting factors that maintain vascular integrity. It activates thyroid hormone from its storage form into its active form. It converts the raw materials of energy metabolism into the compounds that cells can actually use for fuel. When these functions decline simultaneously, the body's entire energy economy is compromised in ways that no single blood test captures, because each individual function may still be within its reference range, while the aggregate performance is significantly below what the body needs. A 2020 study published in Hepatology examined fatigue severity and cognitive performance in adults with early-stage liver fibrosis confirmed by liver biopsy, all of whom had normal or near-normal liver enzyme levels on standard blood panels. The researchers found that fatigue scores in this group were significantly higher than in matched controls without liver disease, and cognitive processing speed was measurably slower on standardized testing. The liver disease was confirmed by biopsy. The blood panels showed nothing. The symptoms were real, measurable, and entirely attributable to liver dysfunction operating below the threshold of enzyme-based detection. If you have been living with fatigue that does not respond to sleep, that has been present consistently for more than 3 months, that coexists with any other symptom on this list, and that has been attributed to stress or aging without a specific investigation of liver function, the conversation worth having with your doctor is not about the fatigue itself. It is about requesting a liver function evaluation that goes beyond enzyme levels to include albumin, bilirubin, prothrombin time, and platelet count, the markers that reflect actual liver performance rather than liver cell damage. Number 6. Itching without a rash, particularly at night. This symptom is specific enough to the liver that hepatologists describe it as a clinical fingerprint. It does not appear in the same pattern with any other common condition, and once you understand the mechanism producing it, the connection to liver function becomes impossible to miss. The liver is responsible for processing bile acids, the compounds produced from cholesterol that are secreted into the intestine to aid fat digestion. Bile acids are then reabsorbed from the intestine, returned to the liver through the portal circulation, and recycled. When liver function or bile duct function is compromised, this recycling process becomes less efficient. Bile acids accumulate in the bloodstream, they deposit in the skin, and at the concentrations that accumulate in the skin during liver dysfunction, they activate the nerve fibers responsible for the itch sensation. The characteristic features of cholestatic itching that distinguish it from dermatological causes are its distribution, its timing, and its resistance to treatment. It typically affects the arms, legs, palms, and soles rather than the trunk. It worsens at night when skin temperature rises and bile acid deposition in the nerve-rich skin of the extremities. It produces no rash, no visible skin change, no physical finding that a dermatologist examining the skin can identify as the cause. Antihistamines provide minimal or no relief because the mechanism is not histamine-driven. Moisturizers do nothing because the problem is not at the skin surface. A study published in the British Journal of Dermatology reviewed adults who had been evaluated by dermatology for unexplained pruritus, meaning itching without a rash, before receiving a liver or bile duct diagnosis. The average time between the onset of the itching and the liver diagnosis was 22 months. In the majority of cases, the dermatology evaluation had been normal, and the patient had been given a diagnosis of idiopathic pruritus, meaning itching of unknown cause, before anyone requested a liver function panel. If you have been experiencing itching without a visible rash that is worse at night and that has not responded to any dermatological treatment, requesting a liver function panel, including bilirubin and liver enzymes, alongside a bile acid level, is a specific and appropriate next step that the symptom pattern justifies. Before we continue, if this has been useful so far, hit that like button so more people can find this information. Subscribe and turn on notifications. New content every week. Number 5. Dark urine and pale stools occurring together. This combination is one of the most diagnostically specific signs on this list, meaning that when both changes are present simultaneously, the number of conditions that can explain them is very small, and the liver or bile ducts sit at the top of that short list. Bilirubin is a yellow-orange compound produced when old red blood cells are broken down. The liver takes bilirubin from the bloodstream, processes it, and secretes it into bile, which travels through the bile ducts into the intestine, where it gives stool its characteristic brown color. Some bilirubin is also excreted in urine, contributing a small amount of yellow color to normal urine. When liver function is impaired, or when bile ducts are obstructed, this bilirubin processing is disrupted. Unconjugated bilirubin accumulates in the bloodstream and is eventually filtered by the kidneys, producing urine that is notably darker than normal, ranging from deep yellow to amber to the color of dark tea or cola in more significant cases. Simultaneously, because less bilirubin is reaching the intestine through the bile ducts, stool loses its normal brown color and becomes pale, clay-colored, or grayish. The simultaneous appearance of dark urine and pale stools is essentially pathognomonic for a problem in the liver or bile duct system. It means that the bilirubin that should be traveling through the bile ducts to the intestine is instead backing up into the bloodstream and being excreted through the kidneys. This is not a subtle or ambiguous sign. It is a specific and direct communication from the liver and bile duct system that something is obstructing or impairing the normal bilirubin pathway. Adults who notice this combination should seek medical evaluation within days rather than waiting for a scheduled appointment. While the cause may be benign, the same pattern appears in early presentations of bile duct obstruction from various causes that benefit significantly from early identification. Number 4. Swelling in the abdomen or ankles without an obvious cause. Fluid accumulation in the abdomen, called ascites, and swelling in the ankles and legs are among the most visible signs of significant liver dysfunction, and represent a point at which the liver's synthetic function has declined enough that the body's fluid balance mechanisms are directly compromised. The mechanism involves albumin, the protein the liver produces that is responsible for maintaining oncotic pressure in the blood vessels. Oncotic pressure is the force that keeps fluid inside the blood vessels rather than leaking into surrounding tissue. When albumin production falls because the liver is not functioning adequately, oncotic pressure drops. Fluid that would normally stay inside blood vessels seeps out into surrounding tissue and body cavities. In the abdomen, this produces ascites, a collection of fluid in the peritoneal cavity that produces visible distension, a feeling of bloating that does not respond to dietary changes, and a characteristic shifting quality when the abdomen is pressed that physicians use to distinguish fluid from gas or fat. In the legs, the same mechanism produces pitting edema, the swelling that leaves a visible indentation when pressed, that is most pronounced in the ankles and lower legs by the end of the day. The distinction between liver-related fluid accumulation and the fluid retention associated with kidney or heart problems involves several features, but the most practically useful for an individual is the coexistence of other symptoms on this list. Ankle swelling from kidney dysfunction coexists with the kidney-specific symptoms described in earlier content. Ankle swelling from heart failure coexists with breathlessness and reduced exercise tolerance. Ankle swelling from liver dysfunction coexists with the fatigue, itching, jaundice, or bruising that reflect the liver's other compromised functions. A low albumin level on a standard blood panel is the laboratory correlate of this mechanism and is one of the most sensitive and specific markers of liver synthetic function available from routine testing. Requesting albumin as part of a comprehensive metabolic panel whenever unexplained fluid accumulation is present adds meaningful information that a standard liver enzyme panel alone does not provide. Number 3. Easy bruising and cuts that take longer to stop bleeding. The liver produces virtually all of the clotting factors that allow blood to form clots when a blood vessel is damaged. Factors 1 through 13, with the exception of factor 8, which is produced elsewhere, are synthesized in the liver. When liver function declines, clotting factor production falls. The blood's ability to form stable clots decreases, and the clinical consequence is a pattern of easy bruising from minor trauma that would not have produced bruising previously, and cuts or small wounds that bleed longer than expected before clotting. This sign is frequently attributed to aspirin use, to blood thinners, to aging, or to fragile skin, and all of these can contribute to easy bruising and slow clotting in older adults. The distinction that points toward the liver is the pattern and the context. Liver-related coagulopathy produces bruising that appears on areas not typically subject to impact, including the trunk, the upper arms, and the thighs, in addition to the extremities where impact-related bruising is expected. It produces bruising that appears with minimal or no identifiable trauma, and it coexists with other symptoms on this list rather than appearing in complete isolation. A prothrombin time, or INR test, which measures how quickly the blood clots and reflects the function of the clotting factors the liver produces, is a direct and sensitive measure of liver synthetic function. It is also one of the tests not included in standard annual panels, unless there is a specific reason to order it. Requesting it in the context of unexplained easy bruising, particularly alongside low albumin or any elevation in bilirubin, provides a picture of liver function that enzyme levels alone cannot deliver. Number 2. Pain or discomfort in the upper right abdomen. The liver sits in the right upper quadrant of the abdomen, beneath the diaphragm and protected by the lower right ribs. It is the largest solid organ in the body, and it is surrounded by a capsule, the glycan capsule, that contains nerve fibers sensitive to pressure and stretching. The liver itself has no pain-sensitive nerve supply in its interior. This is why liver disease can progress silently for years without pain. The capsule, however, does produce pain when it is stretched. When the liver enlarges due to inflammation, fatty infiltration, congestion, or mass lesion, the stretching of the capsule produces a dull, persistent ache, or a sense of fullness and pressure in the right upper abdomen that is often felt as much under the right rib cage as it is in the abdomen itself. This discomfort is frequently attributed to musculoskeletal causes, to rib injury, to costochondritis, or to gastrointestinal problems, including gas and constipation. These attributions are reasonable when the symptom appears in isolation. When it coexists with fatigue, itching, easy bruising, or any other sign on this list, the liver deserves specific evaluation before musculoskeletal or gastrointestinal explanations are accepted. Liver enlargement is detectable on physical examination by a trained clinician who specifically looks for it, through a maneuver called percussion of the liver span that takes less than 60 seconds and provides immediate information about whether the liver is enlarged beyond its normal dimensions. It is also readily visible on abdominal ultrasound, which is the most accessible and cost-effective imaging modality for liver evaluation, and which provides information about liver size, texture, and the presence of any structural abnormalities that physical examination cannot reliably detect. Number 1. Yellowing of the skin or whites of the eyes. Jaundice is the most recognizable sign of liver dysfunction, and the one that most reliably prompts medical evaluation. It is also, in the context of this video, the sign that should never be dismissed or attribute it to another cause, because its presence alongside any other symptom on this list represents a pattern that warrants urgent liver evaluation regardless of what enzyme levels show on the most recent blood panel. Jaundice occurs when bilirubin accumulates in the bloodstream at levels high enough to deposit in tissue. The whites of the eyes, the sclera, are particularly sensitive to bilirubin deposition because of their high collagen content and relatively clear tissue that makes the yellow coloration visible at lower bilirubin concentrations than it becomes apparent in the skin. Scleral icterus, the yellowing of the whites of the eyes, is often the first visible manifestation of elevated bilirubin and can be detected before skin yellowing becomes obvious. In the skin, jaundice appears first in the face and then spreads to the trunk and extremities as bilirubin levels rise. It produces a yellow to yellow-green discoloration that is most visible in natural light, and that is distinct from the slightly yellow skin tone that some individuals have as a baseline, or from the orange discoloration that can result from high carotene intake. The causes of jaundice range from benign and self-resolving to urgent and serious, and the distinction between them requires medical evaluation. What is not appropriate in any case is attributing jaundice to poor lighting, to normal skin tone variation, or to a dietary explanation without a bilirubin level and a liver function panel confirming that the discoloration is not biliary in origin. 7 signs, each of them appearing before the standard testing catches up, each of them attributed to other causes in the majority of cases before the liver is evaluated. The fatigue and brain fog that sleep does not resolve, the nighttime itching without a rash, the dark urine and pale stools appearing together, the fluid accumulating in places it does not belong, the bruising that appears without explanation, the discomfort under the right ribs that comes and goes, and the yellowing that the body produces when bilirubin can no longer be contained. Your liver has no voice. It has no pain signal in the ordinary sense. What it has is these 7 signs, and the ability to produce them months and years before any blood test confirms what they are saying. The pattern they form together is not ambiguous. It is a specific and consistent communication from an organ that is responsible for more of your daily function than any other single structure in your body. Do not wait for the enzymes. Listen to the pattern. Now we want to hear from you. Have you experienced any of these 7 signs without ever having your liver specifically evaluated? And did any of them surprise you today? Share in the comments below. We respond to every single one. Next week, we are covering the 5 foods that hepatologists identify as the most consistent dietary drivers of liver damage in adults who believe they are eating responsibly.